Okay, today we're going to come back and we're going to revisit the OODA loop discussion. Shouldn't be anything new to you guys. We've talked about and discussed the OODA loop before in class. You should be familiar with it. Observe, orient, decide, act. Today though, we're going to come at it from a little bit different perspective. We're going to revisit it, knock the rust off, and hopefully take those concepts that you probably superficially paid attention to because you wondered, what's this going to have anything to do with what I do clinically? Now, since we're talking about clinical decision making, we're going to go back and we're going to revisit that. And now, hopefully, the superficial understanding that you took away from because you didn't think it was that important clinically, we're going to dive in and hopefully make that a little bit more relevant today to our clinical decision making as we go through our assessment process. So, shouldn't be a new image for you guys, should be familiar with it. Again, if we use this and leverage what this process lays out, it can be extremely impactful to helping us with our clinical decision making. And like in the first video, the first time I introduced you guys to this, I said really conceptualize this less as a singular loop and more as a spiral, ever tightening spiral as we make our decisions. That's what we're really going to hone in on today. Because oftentimes with this, we see this, and this top portion here is easy to understand, it's easy to read because it's the biggest part. We just kind of tend to focus in on that. Where the real focus is clinically is what's happening down below. Notice how that starts to tighten up. As we do this, remember with our clinical assessment process, we're not trying to make our egos feel good and confirm what we think is going on because, hey, I was right, I got this. We're trying to exclude all the things that it's not. And when we're dealing with the human body, which when we're dealing with post-op rehab situations, when we're dealing with injuries, when we're dealing with people coming in with pain that they don't know what the source is, we're dealing with having to exclude a lot of things. It's not always a clear, cut and dry A plus B equals C. We have to apply a thought process, apply a process to where we can slowly strip away all of these other factors that may or may not be contributing and get to that deeper level. And that's where really employing this OODA loop philosophy, this OODA loop practice can help us stay on point so that we don't just get mired down in the bog of this is just an ankle sprain. Remember, first time through the OODA loop, we're getting our initial assessment. We're getting our initial round of information and data. That's the initial round. We have to apply. We have to make a decision. We have to act. That act is going to be what we choose to do intervention-wise, whether it's hands-on manual stuff, whether it's some exercise, whether it's giving them a kettlebell and having them do some deadlifts or some presses or whatnot. Whatever we do intervention-wise, remember, that's part of our assessment as well. I'm not just mindlessly giving them a drill. I'm not just mindlessly doing some manual technique. I'm gathering feedback with them. How is their nervous system? How are they responding to this? Because as I get that, that gives me feedback on what I'm doing, how they're reacting, they're responding. That is what allows me to gather that evolving information from my interaction with the individual and their interaction with the environment. I need that information. That feedback is critical to tighten this loop up and start to exclude some things. So as we go through this, as we get that feedback, we are using that to leverage our decision making. We now have information that we've never had before. When we go through our initial assessment, we're just getting them to tell us a story about what historically has gone on, how they've reacted to certain situations, how they've responded to certain things that they've tried to do. For the first time in our dealings with the individual in front of us, we actually get real-time feedback on what we did and how they responded, how that nervous system reacts in response to our interventions, whether it's manual, exercise, or anything in between. That is critical. We've never had that up until this point in our interaction with that person. We just heard stories. Now we can see it with our own eyes. We know what we're doing. know and we can see how they're responding. And that is critical. So how do we know, how do we figure out what's going on? First, we have to have some data. It's wonderful to get some subjective information that tells us how they feel and how they react, and there is value to that. We can't discount that. But at the same time, we can't solely rely on that. It's about their feelings. And remember, feelings are extremely subjective. I don't want to base my clinical decision making and interactions on just their feelings. I need some hard facts. That's where our objective information comes into play. We need to know if things are actually improving, regardless of what they feel. Yeah, they feel like things are getting better, but human tendency, human interaction, human nature is to put a kind of a positive spin on what's going on when somebody's helping them. I don't want to make you feel guilty. You're doing and you're trying to help me and it's not doing anything. I don't want to make you feel bad, so I'm going to tell you that it's healthy. We run into that on a very regular basis. We know that. We have to guard against that. How do we actively guard against that? Objective information. They're telling us what's going on. I need to confirm or deny that with some kind of objective metric. What is that? I don't know. It depends what you found in your assessment. It depends what you identified as a clinical priority. If our clinical priority today is effusion, I might use girth measurements around that joint, above and below the joint. Do my interventions. Yeah, they tell me my knee moves better, my elbow moves better, doesn't feel as bad, it's not as sore. Wonderful. Subjectively, they're telling me good things. If I measure and it didn't affect the effusion, why are they feeling better? I don't know. Maybe it's because I just spent 15 minutes with them, putting my hands on them, and that just kind of soothes their nervous system. That's a clinical outcome, but I know what I didn't affect their effusion, didn't affect the swelling. If I measure and their swelling got better and subjectively they feel better, wonderful. Now what I did had a direct impact on the clinical priority and they feel better. I need to know that. I need some kind of objective data. That's why it's so critical to do a test retest. Not to just say we did a test retest, but so that we have something to anchor their subjective feelings to. Their subjective reporting is now anchored in an objective outcome. And that's more data to help me synthesize and help me decide what my next step is going to be. With our test retest, we do have to have some kind of clinical consistency. I wouldn't recommend, if we look at that, we want to try and keep our clinical test retest kind of the same or on the same path. If I measure somebody's dorsiflexion and I made that better, maybe now I want to look at them in half kneeling dorsiflexion. The original dorsiflexion I looked at was on the table. Now I want to see how they use that dorsiflexion interacting with the world, so I'm going to put them in half kneeling. I can measure half kneeling dorsiflexion. Maybe after I spend some time and clean that up, that looks good. Now let's increase the length of the lever arc and let's put them into the crouching chain shape. Let's see how that looks and how their body interacts and responds to that new freedom of motion that we gave them at the ankle. I wouldn't look at something like, let's measure accessory motion of a joint, we clean that up, we move on to our next thing, and then all of a sudden we're measuring strength. That's a big jump. There might be times where that's clinically relevant, but that is a big jump. We want to maintain some level of consistency in what it is that we're looking at, just so that we know we're continuing to move on in a somewhat linear manner. Now, again, we all understand we're dealing with patients. It's not always going to be linear, but we do need to have some kind of logic with that. And if we can keep our test retest relatively consistent and progressively integrating the original thing that we're looking at, it's going to help us with our decision-making process. It's going to help us stay on point with what we're doing. Now, there are times we're going to go from one test retest to something completely different. That's okay, as long as we have a clinical priority that's driving it. And as long as our thought process is ever evolving and tightening up and moving on to that next thing. So try to keep your test retest somewhat consistent if you're able to. To follow along on how we know if we're moving in the right direction, if that OODA loop's tightening up, if we're getting closer to the thing, we talked about the importance of subjective and objective information to help us. But now, over time, and maybe that's within a session, maybe that's 2 or 3 sessions strung together, we need to start paying attention to the trajectory. is the patient consistently getting better in the time frame that we expect? Recently had a conversation with some clinicians about how on visit 10 the ankle sprain was looking amazingly well and they were extremely optimistic about it. That's wonderful. Visit 10 was 10 weeks after the initial injury. That kind of muddies the water a little bit. You know, in 10 weeks, skilled therapy, yeah, they got better, but I wonder how good would they have been in 10 weeks of just doing stuff at home on their own following Google. That's a completely different picture than they're feeling significantly better. Objectively, everything's looking better at visit 10 when visit 10 is in week 3. So we have to keep an eye on the trajectory in regards to the time. One of the hallmarks of this approach of sports medicine in general is we always consider time, because time is extremely important for us, because we're trying to get athletes back in a very timely manner because they want to get back. A little bit different in our world when it comes to time, because we're trying to push that envelope, not necessarily be aggressive, but trying to push that envelope because we're very sensitive of time. 10 visits, significant improvement week 3, wonderful. 10 visits, significant improvement in week 10, still a good trajectory, but that's a very flat trajectory. I wouldn't say that we were seeing significant improvement within each visit, because it just happened over such a long period of time, and it's easy to lose sight of that. But we know that we can actively guard against that. We can not fall into that trap of just being very myopic and losing track of time. We want to look at this trajectory both within the session and between sessions to see if they're progressing or regressing. This is why I always go back to better, worse, or same. It gets annoying if you're my patient, because I'm always asking you after every intervention, get you up, have you do something. Does that feel better, worse, or the same? And what I typically asking is that better, worse, or the same? Is that objective test retest? I'm objectively looking at it, getting the data that I need for my objective test and retest, but I also want to know how they're feeling, the subjective part. And I always ask better, worse, or same. Obviously, I want all of my interventions to make that person better. Did the right thing at the right dose, had the expected outcome. If I don't make them better, I want to make them worse. That might seem counterintuitive, and I know I've talked about that a couple times, but again, now that we're dialing in on the assessment, hopefully this will sink in a little bit. I want to make them, if I can't make them better, I want to make them worse. Right now, because that helps me with my decision making. Now, if I'm not applying the OODA loop concept and that intervention just makes them worse, and I don't use that to further my clinical decision making, then that's absolutely crap. But because I'm using that feedback to help me make my decisions, what I know when I make somebody worse, I was in the right place, but either I did the wrong intervention, I dosed it wrong, or I need to tweak it just a little bit. I was in the right place, but what I did wasn't correct. I created change, but it wasn't the anticipated change. That might make a little more sense when I explain why the worst possible outcome after any intervention is they feel exactly the same. Because they would have, if I do this intervention, I ask them how they feel, and they tell me they feel the same. My objective data looks the same. Nothing has changed. They would have had that same outcome if they would have been sitting in the chair, not doing anything over the time span I spent working with them. I wasn't in the right place. I wasn't doing the right thing. I'm not even in the ballpark of creating any kind of change. And when I asked them how they felt, nothing felt better, nothing felt worse. It feels exactly the same. When I look at my objective data, it looks exactly the same. I just invested time and energy into something and it didn't change anything. Now, that also is feedback, because now I know not only am I in the wrong place, I'm doing the wrong thing. They could have done nothing and had the same outcome. So if I make somebody better, they feel better and objectively they're better. I'm in the right place, I'm doing the right thing at the right dose. I need to continue advancing, progressing that, and following along that line. If my intervention makes them worse, either subjectively or objectively, I know I'm in the right place, I'm working on the right fascial line, I'm targeting the right thing, but what I'm actually doing, the intervention I'm doing, is the wrong intervention. This is also why I've said multiple times in the TheraX class, or the corrective exercise class, The exercise is the least important part of this. That's why, as we've been talking through this, the interventions are the least important part of this. Because if I make them worse, I know I'm in the right place. I did the wrong intervention. Guess what I do? I try a different intervention that's relatively close to what I just did because I know I'm in the right place. If I work with them and they feel the same, now what I know is not only is the intervention that I chose wrong, where I'm working on is wrong. The thing I'm going after is probably wrong. I have to make a drastic change in what we're choosing to do. I can't pick an exercise or an intervention that's close to what we were doing. I have to go a completely different route and probably, in all actuality, reconsider the path that I'm on because they would have got the same outcome just sitting down on the ground. Are we clinically valuable if they could have got the same outcome sitting down on the ground? Probably not. That's the value of feedback. If I'm not paying attention, if I'm not assessing them while I'm doing my interventions, I lose that feedback. I don't know how to make my next decision. I'm just guessing. And I love the quote Dr. Jimmy Ewan shared with me a while ago. We have to keep in mind when we throw crap up on the wall, the stuff that sticks, it's still crap. That's what it's like if we don't pay attention to the feedback. He didn't use the word crap. If we don't use that feedback with our decision making, the stuff that works, we just got lucky. We have to keep that in mind as well. When we have the data and we have the trajectory, like I said, it will be very valuable helping us make our decision on what the next step is. What's the next thing we're going to do? Where are we moving to? What are we moving towards? We have to continually evolve that thought process and continually run that OODA loop to help us make better decisions to determine what our next action is going to be. I'm running an overall OODA loop process for the entire session with an individual, but I'm also running that individual OODA loop for each individual intervention that I'm doing. I decide on the drill I'm going to do, I take the action, I gather the information, and I just continue that spiral. And that's part of the overall thought process I have for that day and the overall thought process for the duration of that patient's time with me. Come back to why do we gather objective information? This picture's perfect. One side, you have the kindergarten version. It looks like a horse, ties in with a horse. Other side, you have a very artistic drawing of a horse, lots of time and energy. You have a professional that drew that. You have a master that's drawn that, an artist that has drawn that. And I think this picture is a great reflection of how we can apply objective information and how we can gather objective information. Reason number one is to say that we have objective data. We do the test. In the healthcare world, we have to document everything we do. We have to be able to show to insurance we do everything we do. So we do these tests and we gather the information. We put it on there and it makes the insurance happy. Or we put it on there because our employer says we have to gather objective data. Or we put it on there because I have said you need to gather objective data on every evaluation that we do. It has minimal impact on your decision-making process. We're doing it to check off the box. We're doing it to say, yep, we gathered range of motion. Yep, we ran it through the shapes profile. Yep, we did a pain scale assessment. Yep, we ran it through the COOS. And sometimes we have to jump through those hoops, especially with some of the patient-rated outcomes, the HOOS, the COOS, the pain scale. Sometimes we have to do that because insurance requires it, and that's perfectly fine. But when everything we gather objectively is to say that we gathered objective data and we're not changing what we're doing based off of the objective data that we've gotten, we are practicing clinically at a kindergarten level. We're doing it, but it's having minimal impact on our decision making. It's not guiding us in our OODA loop. It's not helping us tighten that spiral up. What does that look like? You have somebody with an ankle sprain. They've been in a boot for 4 weeks. They come in today, 4 weeks after their initial ankle sprain, 4 weeks after being in a walking boot, and you're doing your evaluation on them for an ankle sprain. Kindergarten level, you run them through the critical shapes profile because we have to do that on intake. You determine pass-fail. At the end of that, you run them through ankle range of motion. You do ankle manual muscle testing. You palpate the ankle. You might do a breath hold because in our model, breath hold's important. We gather that breath hold, we do it, we write it down.
Well, let's look at this. You ran into the critical shapes profile. They came in for an ankle. Is any healthcare professional on the planet going to look at an ankle if somebody comes in with an ankle sprain? Absolutely we are. They came in for an ankle sprain. We're going to pay a little bit of attention to the ankle. So why do we run them through the critical shapes? To determine pass fail? That's monkey level, that's entry level. We know the ankle's involved. We need to know what else is going on. So yeah, we did the things, but it didn't help us with our clinical decision making. We still went to the ankle afterwards, which is what we were going to do before. Did we take into account the breath hold on any of this stuff, or did we just document the number? So we can do all of the things because that's what we need to do objectively and to document everything, or because that's what your employer requires. But did it help you in your clinical decision-making process? The other side, the mastery side of this, we gathered the objective data to have an anchor for our interventions and our decision-making. It redirects our thought process because we're gathering feedback from everything that we do to help us tighten up that OODA loop spiral. What does this look like? Same presentation, ankle sprain, boot for 4 weeks. They come in for their evaluation. You run them through the critical shapes profile. We know they're in there for an ankle, but in that critical shapes profile, something at the pelvis is really jumping out at you. So when we finish the critical shapes profile, we run them through some hip mobility testing. We might look at their hip range of motion. They've been in a boot for 4 weeks. We might do a soft single range, a one range of motion, soft one repetition max test, meaning not a true max effort, one rep max, but we get an idea of what their lower extremity strength is because they've been in a boot for 4 weeks. We might, if that's not appropriate, we might take girth measurements because they've been in a boot for 4 weeks. We want to know how their body's adapting to that. We'll do a breath hold test because they've been in a boot for 4 weeks. I'm getting tired of saying that. How is their autonomic nervous system reacting to that, especially in regards to the movement changes that might have taken place because they've been in a boot for 4 weeks? We then go on and we do some ankle range of motion because they're there for their ankle. We palpate the ankle, we might do an anterior drawer test. We do those bottom three because they come in expecting us to do ankle stuff, but we know that information. What's going to help us with our decision is this information up above. We know the ankle's involved. We also know they've been in a boot for 4 weeks. We're going to see atrophic changes to the lower leg. We're going to see adaptations to within the nervous system. We need to know what we don't know. And what we don't know is how their body is adapting to the boot. We use that objective data to guide what we do, not to fill in a sheet of paper. That then might guide us to looking at the foot a little bit more, doing some mid-foot mobilizations. We might look at some additional shapes based off of what we see in the critical shapes process or profile. We might run them through some postural stuff. Again, what we do on the back end of that critical shapes profile is going to be guided based off of what we see. If all we look at is pass fail, it's not going to guide us. If all we do is go straight to the ankle, why didn't we go to the ankle to begin with? Because we would have gotten there anyway. The critical shapes was just a waste of our time. So we have to use the objective data like a master, like an artist, so that we can use it to help us with our next decision, to figure out what we don't know, not just confirm what we already know. If that's the case, we're letting our ego guide what we're doing clinically, and that's not going to be what helps the patient at the end of the day. With this mindset, what we're bringing is a mindset where we're asking better questions. And what I mean by that is we need to ask better questions so that we can get more specific answers to help us come up and make a better decision. The better our decision is, the more precise our actions can be. We're always trying to give feedback. Well, only way we can get feedback is if we ask questions and then pay attention. We can't just mindlessly be going through things, get to the end and look at the outcome. We've got to be asking questions and looking for feedback this whole time. The more specific our questions, the more precise our assessment and critical thinking can become. If we just ask the question, is there a strength issue, we can put somebody on the leg press or whatever strength apparatus you have to test people. We can put somebody on the leg press and we can get objective numbers to see if there is or if there isn't a strength deficit. Do they meet our expectations and standards, yes or no? If we stop there, we know yes or no to that question. Yes, there is a strength issue. No, there isn't a strength issue. But is that a good question to ask? It's a good starting question. If we find that there is a strength issue, now we have to ask why? What's contributing to that? First thing I need to consider in that instance is their history. Is there something recently in their history that might contribute to this? A recent surgery, immobilization. Both of those are going to contribute to a significant strength issue. Both of those are going to influence what my next step is. If it's somebody that's had surgery or somebody that has had any kind of immobilization recently, we know there could be a high potential for atrophy to kick in. The more severe the immobilization, boot, non-weight bearing, a cast, non-weight bearing, is going to be significant, or it's going to contribute significantly more to the rate of atrophy than less immobilized situations where we're just in a sling or we limit our activity. We have to keep in mind immobilization is not just we're in a sling, we're in a boot, we're in a cast. Any time that somebody's activities are decreased or we're limiting somebody's activities, that's a very entry-level form of immobilization. A walking boot, cast, yeah, we're familiar with those knee immobilizers. We have to keep in mind that any form of immobilization, especially in our athletes, can start to drive us towards these atrophic changes. And again, the more severe the immobilization, the more severe the atrophy is going to be, the more extensive it's going to be. So we have to consider that. Well, how can if we have that history of surgery or immobilization, we know there's a strength issue. Now I need to know, is this a force production problem or is this just a size problem? How can I get that information? Simple. Measure girth of the muscle belly. Ideally, we would do an MRI, we look at the cross-sectional size of the muscle on the left side compared to the right side. That's not practical, it's not cost efficient. We can just simply look at muscle mass, girth of the muscle belly. If there is a decrease in size of that muscle belly, now I might specifically want to know how much of that local force production is impaired. So I might do some local force testing with a handheld dynamometer. I might look at knee extension. I might look at knee flexion. Not talking manual muscle testing where we give the subjective 0 to 5 score. I want an objective number with this. And what drove us to finding that very specific local muscle problem, force production problem, was asking the initial question, is there a strength problem? Not being satisfied with just stopping there and asking some more specific questions. Now, is there a strength problem? It's a great question. It's a good starting point, but we can be more specific with that. Is there a deadlift force production issue? When this person is going through a deadlift, 2 coordinated weight shifts, can they adequately and appropriately generate force? How am I going to look at that? Well, first, if obviously the simple answer is I just have them do a deadlift and we figure out an estimated 1 rep max. That's wonderful if the situation allows that. But in a rehab situation, we might not have that freedom right away for lots of different reasons. So I might not want to jump, or might not be able to jump right into doing a deadlift estimated 1 rep max. So what I might do first, if I have this question, is there a deadlift force production problem? I might look at first, can they even get into the beginning of the deadlift and the end of the deadlift? So I'm going to look at those 2 shapes, bottom of deadlift and standing shape. If they can't statically get into those shapes without any kind of external load, we probably are onto something with that. We have to consider that if they can't get there without a load, adding load's only going to complicate the situation. Well, if they do well on that, now I might want to, instead of just going, we know they can get in the beginning, we know they can get the setup of the deadlift, we know they can finish the deadlift. Now maybe instead of just connecting the dots, I might want to statically look at how much force they can generate. I might do some kind of isometric testing of the deadlift. One, we're having them generate force without movement, so it's a little bit toned down for the nervous system. I can see what their spine's doing as they're imparting force into that position, whether or not they can maintain the good position that we saw before I ask them to move through that dynamic range of motion. I might want to see what that is first. I might want to see how they react and respond to load in that static position. And if all that looks good, then I might go to a dynamic test. Instead of going for an estimated 1 rep max where we're working up to 3 reps super heavy, maybe instead I want to do a soft 1 rep max. And we've talked about how to establish a soft 1 rep max versus a true estimated 1 rep max. Then obviously, if I have that soft 1 rep max and everything through that deadlift looks good and they can hold that position well with the load that we have. Maybe with some exposure, we can actually work this into an actual estimated 1 rep max. We have lots of options with this. Maybe it's not a strength question to begin with. Maybe the question I want to ask is, we're concerned about range of motion. Is there a knee extension problem? Well, obviously, if I'm wondering about knee extension, my go-tos are going to be active or passive range of motion. It's wonderful information to have on the table, but we know that they have their structure locally on the table allows us to go into knee extension, or it doesn't. But let's just say they have knee range of motion on the table. They have full extension on the table. We tested active, we tested passive, they have it on the table. I'm not done, because life isn't lived on the table. Life is lived up on 2 feet. I need to see how their nervous system reacts and responds. I need to make sure that when they're standing up in the world, that knee extension that they have on the table, they can access it and utilize it, because many things that we do over the course of the day, one of the lower level things just being normal walking, we have to have full knee extension. If we can't access it here on 2 feet, having it on the table, it doesn't help us. We need to have it on the table and have it in the real world. So once we check active passive range of motion, now I might need to check, does the knee extend in some of our lower postures, the NDS postures? Can I extend the knee in supine? Can I extend the knee in prone? Can I extend the knee in quadruped? Can I extend the knee in some of our kneelings? And then ultimately, can I extend the knee when I get up into some of our shapes? Standing, back rack, short overhead, crouching chain. All of these, this progression from the ground up, from the table to the ground and from the ground up, allows the nervous system to show us how it integrates that knee extension motion that we had on the table, how it integrates that into real world applications. And that's ultimately what we need to have. And oftentimes, we look at it on the table, we never consider it anywhere else. We don't ask the next question. They have range of motion on the table. Do they have range of motion? Do they have that full knee extension accessible to them out in the real world? If they have it on the table, but not in function, not in the real world, they don't have it. We haven't addressed everything that we need to address. Now, the nice thing is, if we know they have it on the table, structurally that knee is capable of full extension. If all of a sudden when they stand up, they don't have full knee extension, well, they just showed us their structure allows it. What's limiting that knee flexion? Now we might be getting into the nervous system. How that nervous system is integrating that knee extension or limiting that knee extension because of whatever might have been going on. Injury, trauma, surgery, swelling, strength issues. But we can't stop with just asking, do they have the range of motion on the table? We have to see how they utilize that range of motion. You have to ask better questions, because that's what's going to guide our interventions. Is there swelling? We run into this one all the time in post-operative injuries. Is there swelling around a joint? Is there swelling in an area? How do we figure that out? It's a simple yes or no. We can observe it, but that's just observation. We need to measure. We need to actually put some numbers to that. We need to measure girth around the joint, around the area that we suspect is swelling. Now, if there's effusion, if there's swelling, that by itself, yeah, we have swelling. That's a good first question. But the next question is, especially if this is around a joint or in a muscle belly, does that swelling affect range of motion? Well, now my go-to is, well, of course, I've measured girth, but now I'm going to measure actual active and passive range of motion on the table. And then I can go on to up and standing, like we just talked about. Then I also want to know, does that effusion, does that affect their ability to generate force? I want to know what, we know they have swelling. We know that. We can look, we can see that. We get a number, we can see that. I want to know how impactful that swelling is to their nervous system and to their body. Is it limiting range of motion? Is it affecting force production? We can check if it's limiting range of motion by a passive and active ranges of motion. We can check if it's affecting force production by using a handheld dynamometer and actually measuring force production around that joint. Don't necessarily want to know that I want to go straight to a leg press with this, though I could, but I need to know how impactful that effusion is. Not just that they have it. I need to know the ripples that that effusion is causing. I also think it's important for us to acknowledge that when we're dealing with patients that have had surgery, patients that have an injury, they're bringing a lot of baggage to us.
And sometimes with all of that baggage, with everything that can physically and structurally be going on with the injury, sometimes it's hard to see what the best path forward for this patient is. And that can be overwhelming. And oftentimes when that happens, we don't know what to do, so we just do something so that we're busy, and before we know it, we're 5 or 6 visits in and we haven't helped the patient. We haven't taken a step forward, we just keep spinning our wheels. I think it's important to understand that if we can't see what the best path is, can we at least see what the next best step is? And this is where, when we have all this stuff going on, having a process that we can fall back on can drastically change and prevent us from falling into that process of just doing the same things over and over, hoping it's going to change because we don't know what to do. And that's where this mindset comes into play. Every question that we ask during our interventions and during our assessment, we should be actively seeking the feedback to those questions. And maybe we're not physically asking those questions, but maybe we're thinking these questions. We should be actively seeking feedback for those questions. Because every time we ask a question, get feedback, and understand that answer, what that does is it's getting us closer to that next step. Now, with this, we have to guard against becoming very myopic and solely focusing in on one thing. This is an ankle, this is an ankle, this is an ankle. But we know that that's human nature. We know that our tendency is going to be to become myopic with this. Instead of keeping a broad picture, as we ask more precise questions, we tend to want to focus in. We know that's our tendency. We know that's human nature. We can guard against that. We can make sure that that problem doesn't happen. How do we do that? We have to make sure we stay detached and take a step back and look at the big picture and keep the big picture in mind. How do we do that? We anchor all of this, everything that we're doing, all of these more precise questions, we anchor this in being able to go back and look at their overall movement behavior. And that's where the critical shapes profile comes in. Because we know our tendency is to become very myopic. If we know it, we know that's going to be a problem, we can actively put in processes to make sure that that doesn't happen. We have all this stuff going on. What do we do? And this is why it's so important for us to figure out the clinical priorities. We have to figure out all of the clinical priorities. And not everything can be a priority. But when we at least acknowledge what all the priorities are, then we can find the next step and not just randomly chase today's pain or today's patient complaint or subjectively what's going on with the patient. But we have to know everything that's going on. And the only way we can do that is by asking the better questions to get the feedback, to get that information. So first thing we need to do is figure out all the stuff that's going on. And we do that through a good assessment. We do that through actively seeking feedback and asking better questions. Once we have all of this stuff, now what do we do with it? Well, this is where the priority matrix comes into play. Once we know everything that's going on, everything that the patient is clinically bringing to the table, now we can attempt to create some order within this chaos. And that's where the clinical priority matrix comes into play. And we'll end up talking about that next time we get together.